He's from Australia. He's educated in the United Kingdom, and he has tons of things that he did about the diabetes epidemiology, the metabolic syndrome, and pre-diabetes, and also diabetic complications. I have two full papers about his works that he's very busy guy, you know, and he did several important things about diabetes. Today he will honor us to explain it, give a lecture about the differences in diabetic complications between Asians and other populations. We are ready to listen to you, Dr. Shah.
Thank you very much for that very kind introduction. So what I'm going to try and do in the next 25 minutes or so is just look at some of the differences between Asian and predominantly Western European populations in relation to diabetic complications, and to try and look to see if we know a little bit about why these differences might occur. So this is actually a summary of some of the data across the spectrum of complications. This was recently published from the ADVANCE trial, we look here in this slide at the percentage of hospital days. So we're only looking at events that led to hospital admissions. We're looking at the percentage of hospital days according to major complications, and then the remainder of them that were not related to these specific complications in the different components of the advanced cohort. So remember, this is 11,000 people taking part in a randomized controlled trial of tight glycemic and tight blood pressure control, and those who came to were at the lunchtime session yesterday that Mark Cooper was talking about would have seen the map showing all the different countries that were involved. But I've just summarized down here the difference between the groups. So we have Asia here, Eastern Europe here, and EME stands for Established Market Economies. So Asia was predominantly China, but also reasonable numbers from India, from Malaysia and the Philippines, and EME was Australia and New Zealand, Canada and Western Europe. First of all, you see at the top, this is the mean number of admissions per participant over the 5 years of the study. And interestingly, it was somewhat lower in Asia than it was in Eastern Europe and the established market economies. But the interesting thing really is to look at the distribution of the causes of those admissions. We see patterns that perhaps we recognize. First of all, looking at coronary disease. Coronary disease was much less common as a cause of hospital admission amongst the Asian population, whereas major cerebrovascular disease appeared to account for about twice as high a proportion of admissions in the Asian population than in the others. Heart failure was less common, peripheral vascular disease was less common, and it's a little bit hard to see on this, but nephropathy was about twice as common as a cause of hospital admission. Now, that was just looking at it in terms of hospital admissions. Here we see incidence, and incidence does not necessarily need to involve hospital admission, but for some of the major complications, with Asia in red, Eastern Europe in green, and the established market economies in blue. And we see somewhat clearer, but a similar pattern as we saw on the last slide, with major coronary events being lower in the Asian population, but major cerebrovascular events being more common, heart failure being less common, peripheral vascular events being less common, and here we see nephropathy emerging as a more common complication. Perhaps we might have expected the difference to be greater there, but that's what we see here in these data, and mortality being lower in the Asian populations. So what else do we see in terms of comparisons? And there are, in fact, a relatively small number of direct comparisons of complication rates in populations of different ethnic groups. But here are some data from the United States. These are US veterans showing a much higher risk of end-stage renal disease in the Asian populations compared to the European, the Caucasian ones. Interestingly, not much seen here in diabetic nephropathy. Perhaps there is a limitation here because this is a medical records review and it relies on clinicians' diagnosis of diabetic nephropathy based on proteinuria or microalbuminuria and coding of that. And there's always some uncertainty when that kind of thing happens, less so when we're talking about a much harder endpoint such as end-stage renal disease. And cardiovascular disease as a whole, significantly less common amongst the Asian than the European origin population. And again, just looking for comparative data, these are some older data from the UK showing that both in men and in women, microalbuminuria and retinopathy were both more common in the yellow bars representing the Asian. In this case, these are South Asian populations resident in the United Kingdom compared to the European populations in the United Kingdom. Now, this is a study that I think has actually already been referred to at this meeting and often comes up in relation to comparisons of the prevalence of renal disease, and that's what I'm going to focus on in the next few minutes, is the burden of renal disease. This is a study done across all these different 10 different countries across Asia, looking at the prevalence of microalbuminuria and macroalbuminuria. It's often quoted as showing a very high prevalence, and there's no doubt that there is a very high prevalence, but it has to be borne in mind that all the people taking part, all the participants, were selected as having not only diabetes but also being hypertensive. One needs to bear that in mind when looking at this and also when comparing this to other data, and it makes it rather difficult to compare to other data. But nevertheless, we do see patterns of difference across the region, with the highest prevalence, albeit in a relatively small group here in Indonesia, but right across the board we see prevalences of somewhere between 40, or here at the lowest, just under 30%, up to over 75%, with some degree of renal involvement likely to be secondary to diabetes. But we always have to bear in mind that microalbuminuria and proteinuria are not specific to diabetes, but can occur for other etiologies. There's some very nice data that have been published on a regular basis from the United States Renal Data Service, and what they've done is they've collected data on from various dialysis and transplant registries around the world, and what they show here is the proportion of all new cases of end-stage renal disease that are due to diabetes. And when we look at this long list and highlight, and you can see them up here, so I've highlighted in red all the Asian countries that were involved, and you see that none of the Asian countries come down at the bottom, and all of the Asian countries are in the top few here, with Malaysia being almost the top, having where diabetes accounts for over 50% of all of those people going on to dialysis or having a renal transplant. Now, we always have to bear in mind some caveats about exactly what this means. Does this mean that renal disease is a more common complication of diabetes in Asian populations? Possibly, but of course it will also reflect the general prevalence of diabetes within the population. So if population A has twice as many people with diabetes as population B, then even if those people with diabetes have the same risk of developing kidney disease, we're going to see twice as many, double the proportion of all end-stage kidney disease due to diabetes in population B, simply because it has a higher prevalence of diabetes. And the likelihood here is that we're seeing a combination of the two. This is a combination of the effects of a high prevalence of diabetes coupled with a greater propensity for people in Asian populations to develop kidney disease once they have diabetes. And one of the other things that's interesting to look at here is what has happened over time. So some of these, but not all of these registries, have got data that go back over time, and here they're plotting it from 1990 to 2006. And this is just showing the rate per million population. So we're not looking here at the proportion of dialysis and transplant cases that are due to diabetes, but simply the rate per per million population. And whether we're looking at Asians in the United States, whether we're looking at Taiwan, or whether we're looking at Japan, the incidence of end-stage renal disease per million population related to diabetes rose markedly from around 50 in 1990 to around 150 by 2006. The other thing that we need to bear in mind in this is how one gets onto a renal dialysis program. And again, that has changed over time. So the further back we go, the more difficult it would be for people with diabetes to get onto dialysis and transplant programs. And as time goes on, that becomes easier. And so part of this increase is due to more people being eligible to get onto dialysis and not just allowed to die of renal failure. But there's a sort of a comparison here, because here we see what's happened to glomerulonephritis, the other major cause of end-stage renal disease, and that amongst these populations, apart from Taiwan possibly, which peaked and then fell again, has been relatively flat across that time period. And again, we're seeing not so much happening amongst the other conditions, although the other causes are also rising, but clearly not as rapidly as we're seeing for diabetes. And we can look at various countries and see this in more detail, and perhaps we might say that as we look at the data from Japan, that the impact in a highly developed health service, the impact of allowing more people who have renal failure to get onto dialysis would be less so, certainly over the last 10 years or so, where one would imagine that the eligibility of people with type 2 diabetes has not changed very much over time. And again, we see this inexorable rise. Here, fewer than 2,000 people per year going on to dialysis or renal transplant from diabetes, under 2,000 to almost 16,000 as we've gone from 1983 to 2006. So a very marked rise over that 20-year period. So let's turn our attention. I think we can safely establish, and probably most people already knew, though perhaps didn't have all the data to hand, that there was a greater risk and burden of renal disease amongst Asian populations. Let's think for a moment about why this might be. And the data here are surprisingly rather scanty in trying to understand this. But broadly, one might think of it in various categories. And I don't know that this is exhaustive list, but I think these are certainly things that there has been some attention paid to, some of which are fairly obvious. So there may be a genetic susceptibility. And it's worth mentioning in that category that the genetic susceptibility may not be something that applies only to diabetes, that what we may be seeing here and observing is a population-wide propensity to renal disease which is greater amongst Asian populations than other populations, and we're simply seeing that reflected in diabetes. It may be, and I'll show you some data on this shortly, that the important role that we all know that blood pressure has in the development of renal disease is even greater in Asian populations, and that small rises in blood pressure may produce a greater impact on the kidney in Asian populations than in other populations. Somewhat similarly, obesity may have that role, and we certainly see that in relation to metabolic disturbance, that very modest increases in visceral fat will easily lead to diabetes in Asian populations, but not so much in European populations. It may be, and Juliana already alluded to this in relation to cancer risk, that as we knock off and treat better some of the most prominent complications of diabetes being cardiovascular disease, that we allow people to survive longer and get the complications that take longer to develop, such as kidney disease. Smoking is, at least in certain populations, very highly prevalent, and as you'll see, there are some data linking smoking to kidney disease. And finally, we need to consider that perhaps one of the problems is simply worse risk factor control. And that if you take a group of people and don't manage their blood pressure, don't manage their glycemic control as well as another population, it wouldn't be surprising if we see more complications. So let's look at some of those data. Here are some data on smoking. This is a relationship amongst male patients from Taiwan with diabetes, risk of developing either albuminuria or proteinuria in relation to smoking. And you'll see that the more that people smoked, the more likely it was that they would develop either microalbuminuria or proteinuria. And the relationship was pretty similar. Whichever risk group people were in, it was seen in the overall population, it was seen in young people, in older people, in normotensive, in hypertensive, in those with short duration diabetes, and those with long duration diabetes. Now, just a quick caveat about this. It looks at first glance